Hello and welcome to MRSI Talks ART, the latest advances of IVF. I am Dr. Angie Beltsos, founder and executive chair of the Midwest Reproductive Symposium International, MRSI. Our podcast is dedicated to experts providing single subject exploration into the advances of IVF. Thank you, Ferring Pharmaceuticals, for your continued commitment to education by sponsoring this podcast. We have on deck today Dr. Amy Sparks, PhD, HCLD, Laboratory Director at the University of Iowa, ASRM Vice President, SART Executive Council, and she will explore ICSI, PGT, freeze-all in her talk, License to Chill. Joining Dr. Sparks is Dr. Eli Reshef. Dr. Reshef is a board-certified doctor in both reproductive endocrinology and infertility and obstetrics and gynecology. He has extensive experience in reproductive surgery, including the correction of birth defects of the reproductive tract, treatment of endometriosis, removal of fibroids, fallopian tube cannulation, and repair, and in vitro fertilization at the Advanced Fertility Center of Chicago. Dr. Reshef also serves on the MRSI Board of Directors and leads our Education and Research Committee. Welcome.
I'm Dr. Eli Reshef from Chicago, and if you ask me who is the person I admire the most in Iowa, it wouldn't be Caitlin Clark, with all due respect. It would be Amy Sparks. Amy and I met while both served on the board of the Society of Assisted Reproductive Technology, or SART, and both she and I just rotated off the board. She continues her service by being the president-elect of the American Society for Reproductive Medicine, our mother organization. Amy combines a unique mix of deep knowledge of laboratory medicine, academic curiosity, and deep commitment to bridging laboratory and clinical reproductive medicine. So without further ado, let me present a case study or case vignette. And Amy would like your expertise on the various aspects of that particular case. Here goes. This is a 34, almost 35-year-old female that has never been pregnant. This is the first retrieval cycle. We had estrogen of 3950 at the trigger. Her progesterone at the time was 1.9. Retrieval netted 16 eggs, 12 mature, 9 fertilized, and she ended up with 5 day 5 blastocysts. So the question is, first, fresh day 5 versus freeze-all. So Amy, if you will, help us understand the freeze-all versus your very poignant comment in 2018, Fertility and Sterility, which was titled License to Chill. And obviously, has anything changed in your view of freeze-all versus fresh embryo transfers since, especially given that SART data 7 years ago started showing a trend of more frozen embryo transfers to fresh?
Yeah, well, first of all, thank you for the kind introduction, Ellie. I'm so far from Caitlin Clark, but glad you have a few friends in Iowa, at least here. So appreciate it. I think this is a really interesting question, and things have changed over time. I mean, early on, the thought of having to freeze all embryos, that was always considered a risk when we weren't doing very well with our embryo cryopreservation services and embryo survival. But certainly with vitrification and good selection of embryos to cryopreserve, I mean, we do as well with our frozen embryos as well as versus fresh embryos. And in some situations, actually, clinics have reported doing better. And so I would say a lot of clinics have shifted to a freeze-all strategy, and we can talk a little bit more about that after we review this case. So for a 34-year-old who's going through her first cycle, and this is just the experience I've had in our program, when her E2's gotten up to just shy of 4,000, and the progesterone is 1.9, we would tend to freeze all the embryos in this cycle and avoid a transfer just for concerns about endometrial receptivity and the initiation of luteinization prematurely. And we also want to avoid hyperstimulation. And so pregnancy certainly can only exacerbate, it enhance the effects of ovarian hyperstimulation. So if we could avoid pregnancy in this particular cycle, it may be warranted. Got a good number of eggs for her and decent fertilization rate. So for this patient, I think we would tend to freeze all. Now, if her E2 had only reached 2,000 and her P4 was under 1.5 in our program, we would proceed with a fresh embryo transfer. And I think that's where we still go against the grain. I don't know if many of you realize that University of Iowa has always gone a little bit against the grain. Starting in 2004, we implemented a mandatory single embryo transfer policy. And gratefully, thankfully, so many programs have followed as ASRM guidelines have indicated that single embryo transfer is warranted for good prognosis patients. Today, we still think that fresh transfers are can lead to good success, and in certain cases, it's warranted and permitted to proceed with fresh embryo transfer. I know that that's not the case in many of my colleagues' programs across the U.S.
And with regard to the programs that primarily use freeze-all without even consideration for fresh transfer, do you have any comment about that? Is it legitimate?
I guess I'm concerned about a couple of things when you just absolutely commit to freeze-all. The first concern is, what if embryo development isn't great and the embryos don't qualify for cryopreservation? Now you have absolutely no chance of success, but if you had a morula or perhaps two morulae to transfer on day 5, if you had prepared the patient for transfer in the fresh cycle, you still have a chance of pregnancy. It's not great, but it's certainly better than the chance of not planning for a fresh transfer, planning on freezing all, and having nothing to freeze at the end of the cycle. I also think that time to pregnancy, we did a recent analysis. It's going to be a research letter. It's in press in Fertility and Sterility. Dr. Sally Solari, our senior fellow, is the lead author on this letter. And we compared our own outcomes of fresh transfers versus freeze-all strategies for patients undergoing their first transfer. And we stratified patients across BMI. One of the other things we do here that's a little bit different is we do treat patients up to a BMI of 50. So we wondered if BMI had anything, could come into play here as far as what our best path forward for helping patients achieve a pregnancy is, fresh versus frozen transfer. Without stratification, we found that overall live birth rate and miscarriage rate did not differ with fresh versus frozen transfers in our program. So these are just our internal data, remember. And really, we didn't see much difference across BMI classification groups, with the exception of, I think, BMI class 2, is it 35 to 39? BMI, the patients who did a fresh transfer had a lower miscarriage rate than those having a frozen transfer as their first transfer. I hope that
So let's switch it up to a different topic. And intentionally, when I created the case vignette, I didn't mention if ICSI was done or not. So let's say normal semen analysis, would you ICSI all? Would you ICSI some? Would you go even further, because the next topic is PGT? Would you ICSI all PGT candidates?
So with a normal semen analysis where we think we can get a good quality inseminant, we would not do any ICSI. We would do conventional insemination in our program. I know many of my colleagues back in the day used to split cases, and some still do. So they do half ICSI, half conventional, just because this patient is nulligravid. Fear of failed fertilization with conventional insemination certainly is out there. But the majority of programs today, I think, are just automatically doing ICSI. Some of the decision making on standard insemination, though, I still feel relies on having a really good quality andrology program. And good quality andrology lab. And that isn't necessarily part of every single center. They can prepare sperm for IVF or IUI, and they can do a semen analysis, but I don't know that there's that much attention to the insemination decision. And frankly, sometimes it's easier just to do ICSI straight up. That's not what we would do here. It adds to the cost. There is still some innate risk of doing ICSI. And if we can avoid it, we do routine insemination.
In your program, Amy, who makes the decision to do ICSI, the clinician or you?
I do. And I think I'm a little unique because I've been around a while, and I remember the days before we had a wonderful tool of ICSI. So during that first decade of having ICSI available, we learned a lot as far as how to strategize and come up with the insemination plan. I think that learning hasn't been available to the younger generation of practitioners, and it may be lost over time. I don't know. We'll see.
Let me take it up one other notch, and that is the idea of pre-implantation genetic testing for this almost 35-year-old. And would you consider that, number one? And then, if in your program, would you do ICSI on anybody going through PGTA?
Okay. Can I answer your second question first?
Sure.
Is that okay with you? So for the use of ICSI for PGTA, it's not required. The chemicals that are used for the process of doing PGTA aren't strong enough to break. My understanding is to digest the DNA of the sperm. That was one of the first explanations that we were given. And now that we're doing most of our biopsies of trophectoderms, the risk of accessory sperm contaminating your biopsy is quite low when you're doing PGTA. PGTM is a totally different thing. So for PGTA, we'd do a standard insemination here if we could. Would we do PGTA? We looked at SART data a couple of years ago and saw that PGTA definitely did not benefit patients' cumulative live birth rate when they're under 35. 35 to 37-year-old group didn't have a benefit in cumulative live birth rate per cycle, but they did have a lower miscarriage rate with PGTA. Personally, I'm seeing a lot of young patients coming through our center that do have great insurance coverage, and that coverage includes PGTA. And I think the message is being given to these patients that absolutely we'll support your desire to do PGTA. And it's really difficult to talk the young patients out. But I do worry that we miss out on some opportunities of transferring embryos that maybe diagnosed as a mosaic. We will transfer mosaics, we'll transfer segmental aneuploids, we'll transfer all diagnoses here, but it does make patients nervous and steer them away. And I just don't see how PGTA is benefiting really many of our patients under 35. I think the harder part here is that we've opened a recurrent pregnancy loss clinic. And so we have a flood of these patients diagnosed with recurrent pregnancy loss coming to us, wanting IVF and wanting PGTA. And I can't blame them, but we all know that even IVF is not necessarily in, first course. It's not first course of action for recurrent pregnancy loss, and often can't fix the problems that are causing the recurrent pregnancy loss if they're not chromosomal.
Yeah. Next question is a little more general and just requiring your historical perspective and expertise. Has anything changed in the lab in the last 8 years regarding embryo freezing protocols?
Not, I mean, there are many people who have jumped on the bandwagon of doing the ultra rapid vitrification. Some of us haven't, but I think the majority of us have definitely joined the ultra rapid warming protocol. So I think that we aren't seeing a difference in outcomes. There's a huge satisfier in the lab when it only requires 2 minutes to warm an embryo versus 12 minutes or whatever we were doing with those slower warming protocol post-vitrification. I think that's probably the biggest change. I don't know if ultra-rapid vitrification, I don't know how frequently it's been adopted across the US. And if you're vitrifying a bunch of embryos, a high number, I'm not sure that it improves your efficiency as much. But when you're doing a thaw, hopefully you're only warming one, and going from 12 minutes to 2 is remarkable in the lab. Or 1 minute, yeah.
And here's another general question that requires your experience. What constitutes a high quality in vitro fertilization lab?
Oh. Well, I think it's a lab that is diligently measuring key performance indicators on a daily, weekly, monthly basis, looking at fertilization rates, embryo development rates, oocyte recovery rates, oocyte maturity rates. But while you measure these, and some cases will not hit your benchmark or your thresholds, you have to appreciate that this is a survey that takes some time, and you shouldn't react to 1 incidence or 3 instances, perhaps. Failed fertilization, I think that would warrant a stronger reaction when you weren't anticipating it. But you have to look for the trends of your fertilization rates and the trends of your blastocyst development. And there's some nice tools in SART-Cores that can offer you trend analysis for your FERT rates. Blastocyst is coming. I think that's a really good quality lab. And I think it's just great communication amongst all the lab staff, andrology, in vitro embryology, and no matter how much space they have in their labs from a footprint size, they all kind of work as a ballet. It might be a tight ballet, or it could be really broad, huge screen. But it's a dance. You all have to work and flow and make sure all the work is done each day and throughout the week, and that the inventory is there, and everybody's performing at their optimum best.
Thank you. And let me summarize then what I perceive are your recommendations from the case that I presented. Given the data that I presented, you probably do freeze-all because of the elevated estrogen and the elevated progesterone, both from the standpoint of not having a healthy environment or receptive environment for implantation with fresh, and also the risk of ovarian hyperstimulation syndrome, even though we've seen the risk diminishing when we use antagonist protocols and we don't trigger with HCG. Based on her age, I think you would be very hesitant unless she twisted your arm to do PGT. But I assume you would not deny it, especially if she's ready to bear the cost of insurance pays for it. Based on your recommendation, ICSI can only be done selectively, and normal sperm typically constitutes a recommendation for conventional insemination. So an ICSI, not ICSI all, you use it very selectively, and you would not use ICSI automatically for if you perform PGT-A, even though you do so when you perform PGT-M.
You did a beautiful
Anything
summary
else
there.
to add?
No, that's perfect. And the decision to transfer versus freeze-all, that's a conversation between the physician and the patient. I mean, if the patient really wanted to do a fresh transfer, we would use a dual trigger, HCG and Lupron. Hopefully that would reduce her chance of hyperstimulation. But it's a conversation, between the patient and the physician, and the lab will do as ordered.
Well, I appreciate that. And it's, I also, having worked side by side with you, I realize the importance of having people from the lab in leadership positions who interact with the clinicians. So we, the clinicians, are not the dominant force in the field of reproduction. That's very, very important because the input from people who are in what I consider to be the engine room of our ship. The most important aspect of in vitro fertilization in my mind is the lab. Those people like you should be and continue to be in leadership positions. So I really appreciate your contribution for our podcast. We look forward to hearing you in our actual conference in July, on July 26th through 29th. And if you want to stick around after that, you can even go to Lollapalooza the next weekend. So, Amy Sparks, thank you for your insight and thank you for your friendship.
Thank you so much for this invitation. I've really enjoyed the conversation.
Dr. Amy Sparks, thank you for the license to chill. And Dr. Reshef, thank you. If you want to hear more from Dr. Sparks and Dr. Reshef, join us at the 2026 MRSI in Full Bloom annual conference, July 26th through the 29th at the Drake. In the meantime, join us in June on MRSI Talks ART, the latest advances in IVF. Our vision: to bring the world more babies by being a beacon of change, inspiring curiosity, pushing boundaries and advancing science, and uniting minds. Thank you.